Welcome to PDExchange, the Peritoneal Dialysis podcast. As always, I am Nikhil Shah, a nephrologist at the University of Alberta, Canada. And with me is Jeff Perl, a nephrologist at St. Mike's Hospital, University of Toronto, Canada. Jeff is also the editor-in-chief of PDI. Today, we have a special series of papers to be discussed. These papers are some of the selected papers from Peritoneal Dialysis International over the last 18 months to 2 years. And we have the Deputy Editor-in-Chief of PDI, Dr. Yeoungjee Cho. She is a nephrologist at the Princess Alexandra Hospital in Queensland, Australia.
Thanks, Nikhil. And I want to thank everybody for listening to our second PDExchange podcast. Yeoungjee, it's really great to have you on. And I just want to take this opportunity to congratulate you on winning the John Marr Award at this year's ISPD Congress in Singapore, which is taking place in August. So congratulations and really well deserved. And I just want to say that it really is fantastic working with you on Peritoneal Dialysis International. It certainly has been a learning curve for me in terms of understanding the scope of research in PD and really understanding all the fantastic things that are being done around the world. But of course, with any journal, we have to be exceptionally selective about what articles we accept for publication. And, we do review a fair number. And, sometimes there are really difficult decisions that have to be made in the editorial realm of the journal. Yeoungjee, what's your experience of some of the things that you would advise people publishing in PDI? And we're going to focus today really on clinical research because that's going to be the focus of today's podcast. But thinking about clinical research, what would be some tips you would say on some of the ways in which prospective authors could get published in PDI? What do you think would be things that we'd be looking for?
Thank you, Jeff, and thank you, Nikhil, for having me. It's my absolute pleasure to join the session today. And that's a very tough question at the end of the day because, research is hard work and everybody tries to do their best to try to, value add information and data to benefit patients and the research community caring for patients receiving peritoneal dialysis. From the journal's point of view, I think it's really important that the research that we publish align closely with the patient priorities, and that is a value add to the existing literature. Because there is a lot of emphasis and attention on research waste. And I think it's really important that what we do, try to make a difference and try to value add so that we can grow knowledge and information sharing going forward. I think from the editorial sort of point of view, that originality and novelty is important aspect, and methodologically well executed is very important to ensure that what we're publishing can be relied upon at the end of the day.
Yeah, and I wanted to echo that and say, methodologically, I think it's really important to have very solid statistics, to have a very solid methodologic plan. And I think sometimes some of the articles that we review are really very original and have, really excellent ideas, but may fall short because there isn't that methodologic rigor to back them out. For example, a lot of papers are looking at an intervention and they're trying to understand the impact of a novel intervention. It's really something perhaps that hasn't been done in PD before. But in the absence of, for example, a control group to compare and accounting for a control group and adjusting for factors that might be different in the control group and those getting the treatment, assuming it's not a randomized controlled trial. And we'll talk about those and the lack of those in PD in a minute. I think it's important, to understand that you need a control group if we're going to evaluate a new therapy. And sometimes I think that that's a challenge. Or the fact that, we really need to be transparent about how a cohort was selected. And I definitely think that one thing that prospective authors could do would be to go through the Strobe statement and make sure that, your article conforms to the Strobe statement. I think that's a really good blueprint. I think one of the things you said really hit the nail on the head for me, which was, really clinically relevant and aligned with patient priorities. And I know many of us have published papers thinking that it's another publication to line our CVs. And, Joanne Bargman and Mark Lambie argued about the role of biomarker research in peritoneal dialysis. And I continue to struggle with papers that are, biomarker X, outcome Y, really bringing it back to the patient and really bringing it back to clinical use. So, I think just because something has an association with an adverse event, I think I've been a little bit more critical saying, well, what's the implication of that? How is that going to be used in clinical practice? Is that a marker of multimorbidity, or is that something we can modify and course correct. And I must say, in my role, I've been a lot more critical about evaluating those biomarker type studies. I don't know, Yeoungjee, if you'd agree.
I think that they have their own place, but certainly there is a limitation on emphasis and a weight you can place it upon. I am also guilty of doing papers whereby the biomarker has taken a big presence, and that was during my PhD. And I do think that it's really important as a part of a learning process. And you can't evolve and become better unless you make mistakes in any field of work or research. And I think it's really important. And probably the on the note and of the statistical support and etc. Some of us are very fortunate to work in an institution where access to such services are readily available. But I completely acknowledge that that is something that is not equally applicable for everyone around the globe. And what I really want to highlight to the researchers is that we live in this world of virtual community, and you can reach out to work together, and collaboration is a real key for your learning and building strength and expertise. And I strongly encourage that. And I think it also improves your chance of being able to share the work that you have generated.
And I think one of the offshoots I've realized is that we as PDI and the PD community and ISPD probably has a role to play to help mentor and nurture research. And certainly, I think one of the things that many of us would like to do is help share some of the expertise that might exist in helping perhaps some centers that may have less experience with research get off the ground. And so I think you mentioned a really important point about resources that are available for research and how that can sometimes challenge some of the research that gets published. And so we're definitely cognizant of that. And hopefully the ISPD can be a resource to help improve the quality of PD research globally by sharing expertise. So I think methodologically, we're looking for very sound methodologic research. I would say originality is really key, and there's been some really fantastic papers. I want to thank everybody who chooses to submit their work to PDI, and we know how hard it is in selecting a journal. And thank you for supporting it. I would say that PDI has the biggest PD impact factor. Everybody in the PD community reads PDI, so your work will be noticed by the entire PD community. And I thought what we could do in the remainder of the time of the podcast is just talk about some of the articles that we found very interesting and thought would bring up some important points worth discussing. And by all means, this is not an exhaustive list. There were some excellent articles in PDI, but these were just some that if you come to Yeoungjee's lecture at the Best of PDI session, you'll hear a little bit more detail about, but just some articles worth highlighting and just discussing why we thought that they were really interesting to bring out. I think the first one that we'll mention is Outcome Measures for Technique Survival Reported in Peritoneal Dialysis, a systematic review. And I think, Yeoungjee, you were particularly excited about this one. Do you want to tell us a little bit about why you thought that this was something that we would be worth mentioning in terms of high quality research in PDI?
Thanks, Jeff. As many of you know, the SONG initiative, which stands for Standardized Outcomes in Nephrology, based in Sydney, Australia, has really led the work of trying to identify core outcomes that should be reported in all research involving patients with kidney disease. And this work stems from the work from the SONG PD group, whereby technique survival was identified as a core outcome. And, in order for us to speak a universal language, for us to be able to measure the outcomes consistently in a homogeneous way that reflects the patient priorities, the first homework that you need to do is to canvass what the actual scope and heterogeneity of the existing measures are. So Emma has done a great job in actually, describing this by looking at the all published randomized controlled trials reporting technique survival. And in this study, what she really eloquently identified was that there are two main variables that differ when it comes to this outcome according to different trial groups. One is whether death is included or excluded as part of the definition of technique survival. And second is what's the minimum duration of hemodialysis that is required as a qualifying criteria. So some studies completely fail to mention this, whereas others leave it to your discretion, whereas others give you a minimum duration, for example, like 30 days or 90 days. And this may have a different impact on actual event that is being identified as what people describe as technique failure. So I think it's a really exciting step forward.
Yeah, and I think that's really important because one of the main challenges in PD, and we all know this as practitioners, is that unfortunately, many patients prematurely terminate PD therapy to transition to an alternate dialysis modality. And I'm just going to put a plug out there and say, if you go to the PDI website, we're really trying to standardize our nomenclature. And I think we should be moving away from the term technique failure. Failure implies that a patient failed, or the therapy failed, or the treatment team failed. And there's a lot of Twitter discussion, if you follow Twitter, about trying to reevaluate what we're going to call transitions and the actual terminology to be used. So I think one thing that's really important is to standardize terminology, but you're absolutely right. This is something that countless studies are looking at, and Song identified transition to hemodialysis as a core outcome. Am I right, Yeoungjee?
Yes, yes. And the workshop was held late last year. Analysis is underway, and hopefully we'll be able to have a defined metric that reflects the priorities of patients and clinicians and all key stakeholders, so that we can all have a very consistent way of measuring and reporting this very important outcome.
And I think that this is the first foundation of that. It's like, what is the literature really telling us about how people are reporting it? And as you said, this is a really important systematic review that really looked at the issue and tried to standardize it, and builds, I think, on a lot of work actually in prior issues of PDI were done in ANS data, looking at different definitions qualifying off PD to look at technique survival. And again, it's in the details, and it's hard to cross compare studies if you don't apply a standardized definition. And so moving along that theme of technique survival and standardization is another paper that I think is worth mentioning. And this was a paper, Alex Clark is the first author and Rob Quinn is the senior author, on 4 steps to standardize reporting of peritoneal dialysis technique failure, proposed approach. We'll forgive them for using technique failure. This predates the change in PDI terminology. And I think that this is a really good example of using a real world data set to try and articulate what happens when you do apply different definitions. And so, Yeoungjee, do you want to tell us a little bit about why you thought this was really interesting and a couple of take-home points on this paper?
I think it really hit the nail on the dot there with regards to why this article is so important and valuable, because it's almost like a real life example of what it looks like when you vary how the components of definition that exist in existing literature. So I think that, and what they've done is they looked at the data from patients from 10 Canadian centers and looked at the outcome by 4 different stepwise approach. And what they learned is that by having hemodialysis duration as a qualifying criteria, the event rate of technique failure or hemodialysis transfer can vary by 16% plus minus. Okay, so it has a huge impact, and just really neatly, and it's very eloquently done. And I really congratulate the authors for demonstrating this so clearly, and it adds justification to the work that is being done through the Song PD group.
Yeah, and I think it's really just taking something that we all take for granted, just, transition to hemo that's been in so many studies, and really applying it to a methodologic rigor. And I think, Yeoungjee, if I'm not, mistaken, and you're the trialist amongst us, the expert, this is really an important step. If this is going to be an outcome in a randomized trial, we have to make sure, and if randomized trials will be forthcoming in the PD community, we really have to make sure that all future studies are really applying the same outcome measure and measuring it in the same way. And I think this is really foundational work to do that. I don't know if you would agree about that.
Yeah, most definitely. I mean, the key thing about technique or, transfer to hemodialysis, trying to design a clinical trial that's powered to assess that, okay, requires a large number of patients. And obviously that requires a lot of funding support, and we need to do a global study. And doing a clinical trial of that scale is not always feasible. And one of the key things about this that we can't work together at a global community is because everybody's reporting and measuring in a different way. If we have a consistent way of doing it, we would be able to cross compare and look at the data in wholesome. And I think that's a really important step forward. So, and then you've clearly shown that for, I think, as part of your PDOPS paper a few years back, Jeff, about in registry setting, how variable they are as well. So this will have an impact on every aspect of the clinical research and care and for patients receiving peritoneal dialysis.
Yeah. So I think congratulations to Drs. Quinn and Clark for really, I think, helping move the field forward, with proposing standardized definitions and terminology. And if we're going to apply those, one of the things we definitely all are interested in as PD practitioners is maximizing the utilization of home dialysis, because I think in many areas there's a relative underutilization. In my neck of the woods, a paper was published called Growing Home Dialysis, the Ontario Renal Network Home Dialysis Initiative, by former editor-in-chief of PDI, Peter Blake, and Rebecca Cooper. And I think it's a really great paper because in my mind, it said that there's really needs to be a multi-pronged approach to growing home dialysis. You can't just do one thing. You've got to look at all the issues. And, in previous issues of PDI, there's sort of a systematic evaluation of what it takes to get a patient from CKD or urgent start all the way to establishing them on home. And I think that this was sort of a multi-pronged, real world. This is what we tried to do to grow home dialysis. And of course, they succeeded with significant growth in home over the period of time. And I think, in my mind, I think it's something that could really be applied in other healthcare settings and obviously modified to suit the needs of those specific healthcare settings. What struck you about this paper, Yeoungjee, as particularly interesting?
I think that this is a real key example of why PDI is such an important journal for PD community. As you said, I think Peter has written this paper with such sophistication and level of detail to be able to be applied in other healthcare settings and jurisdiction as an important learning lesson of what are the things that you need to consider and what you can do. And it's a really nicely written paper, and I think that's I have learned a lot by reading it as well, and things about what the take-home messages are. And I think we live in a community where we can learn from each other's experiences, and this is a really good example of that.
And I think you're right. What they did, multi-pronged, hits on a lot of points of some of the papers we'll talk about. It talks about assisted PD. It talks about the need for a catheter insertion, use of urgent start PD, having education in all the renal programs in Ontario. I think a lot of the papers resonate and hone in on some of these themes that were implemented in a multi-pronged approach. So really a great paper, I think, for anybody in an area looking to grow home dialysis to think about. And we know that the issues are very different in different parts of the world. And perhaps the Ontario experience in a high income environment might not be as applicable or generalizable to lower income settings. So I think, again, I also think what makes PDI wonderful is the fact that it's a global journal, and we try our best to make sure that all issues are addressed from all perspectives in all environments, including some resource limited environments. And I think another paper in perhaps a slightly different environment was the one by Dell and Nanayakara, looking at overcoming barriers and building a strong PD program, experience from 3 South Asian countries. And this was really great because it wasn't just one country's experience. They really pulled together some important insights from 3 different countries. And hopefully this can be applied to other healthcare settings. Yeoungjee, what struck you about this? Is there anything you want to sort of point out in this particular article?
Look, I think the themes of this paper are not too dissimilar to the Ontario Renal Network paper that was mentioned just before. It needs to be multi-pronged, targeting not just patients, but also care providers and the funders or the government body. But the issue particularly affecting these areas that are with the low resources that are unique to do with the cost burden of peritoneal dialysis that are really directly imposed on the patients. And this paper really nicely articulates, what are the things you can do? For example, the cost of PD fluid is extremely high in these, developing countries. So advocating for, local production or lowering the tax or the border tariffs that are imposed upon, the things that are really unique to these regions can be considered, that can be applied in other similar countries. So look, I think these 2 papers really complement each other very well. They have some common themes and some that are unique to different economic position of the country. And I think they are really lovely. They're really well done. Yeah.
And I just want to encourage, for those of you that are in resource limited or low income settings, these are really important papers for PDI. If you've done something novel, if you've been able to pilot a PD project in your country and you're able to, or your environment, grow PD, I think those are important accounts that we really want to hear about in PDI. So kudos to that group. Okay, switching gears now to a randomized control trial. And unfortunately in PD, they're far and few between. The burden of kidney disease among patients with PD versus conventional in-center hemo, a randomized non-inferiority trial. And again, this was a tremendous initiative, a lot of hard work, many years of sweat and tears to get a randomized control trial off the ground. And kudos to Junior Alfred Yang and Shu-King Yu and the entire group that made this study come to fruition, where 725 subjects were randomized to either PD or hemodialysis. And it really, their PD was found to be non-inferior to hemo on the burden of kidney disease scale. So this was designed and looked at from a patient-reported outcome perspective, and really, I think, established that there's really very little differences in these metrics between PD and hemo, which I think is important because it continues to establish PD as a viable therapy and continues to advocate for the role of expanding its utilization. Yeoungjee, do you want to comment a little bit on this study and tell us what you think, how can we increase randomized control trial development and publication in PD? And I know we very much fall short compared to other areas in medicine.
I think this paper is particularly exciting from two fronts from me personally. Number one, this is not only a study with 725 patients with receiving kidney replacement therapy, but it's across 36 sites in China. So a large number of dialysis units and patients across different centers. And that's really important for the generalizability of the outcomes that are from a trial in the first instance. Second aspect of this trial that I really find is, amazing is that the primary outcome of this study is burden of kidney disease. I think it's really exciting that we're now starting to see trials whereby patient-reported outcomes are becoming a primary outcome, because we have been very much prioritizing the hard clinical endpoints or what the clinicians felt was an important outcome for patients, rather than thinking about what was important from the patient perspective. And I think that's very exciting that we are going in that direction. With regards to the trials, they are hard work, but they are the best quality evidence that we can generate. And I think it's really important that we work together as a PD community to do trials at a global scale so that the results that we generate can be generalizable to the others. And I think it's really exciting that with the change in technology and development, ability to work together virtually, the opportunities to do that are likely to grow. And hopefully, through ISPD and the membership and, PD, closer, tighter PD community, we can make that happen.
Yeah, I 100% agree. And, it sounds like we're working up to that. We're working up to standardized definitions. We're identifying priority areas with our patients and care partners as partners in research. We are now starting to see randomized controlled trials get published. So yeah, I think exactly. I think the tremendous work, the number of sites involved here, really a testament to the hard work of this group. And I hope to see more studies, and collaboration is key. And so I think it's going to be exciting to see more randomized controlled trials. And I know you're working on trying to develop many, and many of us are, in awe of all this, the work that comes out of Australia in the randomized controlled trial nephrology realm. I think to that point, a deeper dive sometimes is really not possible, with standardized instruments and just, basically collecting information from patients using standardized instruments. Sometimes we really have to dig deeper with a much more intense qualitative review. And I really like this paper on patient and caregiver perspectives on burnout in peritoneal dialysis, where we really identified some really important themes with a focus group of 81 patients and 45 caregivers. And I think, it's really important to get patient and care partner perspectives. Burnout is a really challenging issue in PD. And I really liked how they were able to parse this out and get us some really important information. Yeoungjee, I know this was also an article that you found quite interesting as well. Do you want to comment a little bit about it from your perspective?
Sure. Look, I think that it's doing qualitative research and reading qualitative research papers. I think it really gives us a very deep understanding of what patients want and their lives. And it is quite, and actually, and as a trialist, it inspires me personally to think of interventions and ways to improve and mitigate against that. And I think that this is an important step forward. And, burnout ties in very nicely with regards to ways to change how we deliver PD for patients. And I think we're going to be covering a couple of papers after this that really highlight it. So I think it's a really exciting step forward and really important for us to consider.
Yeah, and I'm hoping that as a PD community, I want to thank Corinne Manera for serving as our associate editor for qualitative and patient-oriented research. And we'll hopefully have her on a future podcast. But I think it is important. And I'm hopefully we're getting more comfortable with seeing this research being featured more prominently in PDI, because it's really important. And on the whole spectrum of support and burnout is a paper that I think was really important as well: Assisted PD Across Europe, Practice Variation and Factors Associated with Availability, by Anita van Eck van der Sluis, and last author is Alfonso Abrams from the Netherlands, really canvassing a scoping survey as to what's exactly happening, the delivery of assisted PD across Europe. And, assisted PD, it's so heterogeneous in terms of who's doing it, how it's being paid for, how many visits a day are taking place, what modalities are being supported, that I've realized, just talking about assisted PD opens up a Pandora's box for very many different models of care. And I think in this survey, we realized there is variation in whether assisted PD is even available. And I also think that it certainly brings to light the whole concept that there may be variability in terms of how assisted PD is practiced. Yeoungjee, do you want to comment a little bit on this in your own perspective too?
Look, I live in a country whereby assisted peritoneal dialysis is not offered or available for our patients. So I read this article.
Not yet. Not yet. There's a randomized controlled trial. There's a randomized trial to be had.
So I read this article with much envy, because I feel like this is something that really should be offered. And I read it with the particular interest of trying to understand, what are the characteristics or resources or the considerations that we need to think about in delivering this and offering for our patients. Because not too infrequently, and where I live, patients who are frail, who can't do their own peritoneal dialysis, are in-center hemodialysis, and quality of life really is, in my opinion, suboptimal. So look, it clearly highlights that there is a huge variation even within Europe with regards to, where are the regions where this is more offered. I think it was particularly more prominent and common in like Western Europe and Scandinavia. And also it ties in very neatly with the size of the units and the resources. And I think that's a really important reflection of kind of dedication and services that each units provide. I would really encourage these authors actually to follow up on this and look at the outcomes of these units and see how they, because this was a very initial sort of a preliminary paper looking at the scope of assisted PD. I'll be quite interested to know what the outcomes are like, because it would be important lesson for the global community to learn from.
Yeah, and I agree. And I would also encourage them to pursue some qualitative research on the perspectives of individuals and care partners receiving assisted PD, and how that impacted their modality decision-making and their experience of PD. And that's really important. And again, along the theme, and which I think is really important, are strategies and interventions to help support our patients, which I think is really important work that's been published in PDI, is flexibility in the peritoneal dialysis prescription, impact on technique survival. First author is Navaratnaraja, and Edwina Brown is the senior author. I think that it is important for us to really, take things that we've published, like ISPD guidelines looking at high quality PD delivery that talked about patient-centered PD, patient-centered decision-making. And I think the main theme, and one of the main themes of those guidelines that we published last year, is there's not one size fits all for how to practice PD and what the goals of care are. And I think this group really put their money where their mouth is and really talked about how the PD prescription is flexible and how that does impact patient outcomes. So I really particularly like this. again, I think what makes this very novel is how they looked at differences in prescriptions and what happened over time. Yeoungjee, what made you, think about this paper and highlighting it?
Well, I think this paper ties in very nicely with the topics that we've just discussed to date, patient burnout, quality of life, burden of therapy, and then how can we make PD less burdensome and more flexible for our patients? And I think we are all on the same page when it comes to that. But I think where we're missing is how do we best deliver that? What's important for patients and what's safe for patients? Because as clinical care providers, we want what's best, but, and we need to compromise that with the quality to some degree. And I think this is a really, really lovely paper because how we define or set, incremental peritoneal dialysis, which is obviously a hot topic in peritoneal dialysis community, is uncertain at present. And Dr. Brown and the team here really have put together different ways of defining this. And rather than calling it incremental, what they've done is calling it a reduced peritoneal dialysis by allowing flexibility, not just in the frequency of exchange a day, but also the number of the days of the week where PD is being delivered. So it does meet one person's life requirements and needs. And I think it's really important that we are perceptive to that, because in the name of incremental, we can actually be very, very inflexible, and that might not actually meet what the patient priorities are. And I think it's important that we remember at our core why we are doing what we're doing. So I think it's just a really important step. Probably we need more data, but when it comes to more data, we often look at the registry, which have a lot larger numbers, looking at the hard clinical endpoints, something like technique survival. But often the registries do not let the granular data, like the detail of the PD prescription, which this paper offers. And I think that's why this is such an important manuscript.
Yeah, I absolutely agree. And one of the final ones we'll talk about is incremental PD in incident end-stage kidney disease patients, a single center experience from Toronto, published by Hao Yan and Joanne Bargman, just talking about looking at how incremental PD was prescribed and what happened to the prescription over time. And I think that, when in the early experience, when I think now incremental PD is something that we're really excited about and looking forward as a therapy that might reduce burnout and might be associated with superior outcomes and worth evaluating. This is what I would call sort of the description of an initial experience. Just really, the value in this paper in my mind is just describing how a very large tertiary care academic center with a long history and legacy of PD was able to incorporate incremental PD as part of the practice. And I think it's an important stepping stone for us to then take this data and say, we really need to rigorously evaluate incremental PD in terms of a future randomized controlled trial. So I thought that this paper was worth mentioning because I think it's a stepping stone to a randomized controlled trial. And again, when there's novel therapeutics and interventions, we're not expecting that, evidence is going to be generated from the get-go, but hopefully, we don't, the buck doesn't stop at observational data, or the buck doesn't stop at single center reports, that they remind us that there is a need to collaborate and as a global community design a randomized trial. And I agree, incremental PD is really something that I'm hearing more and more of all the time. But I do think that we owe the PD community a rigorous evaluation of it in terms of a randomized controlled trial. But agree, how do we define it? How do we increase it? What are the important outcomes to measure? What are some of the things that patients might be concerned about? And I'm going to end here and say that all the papers we talked about really triangulate around all those important themes when we're trying to look at it. And so with that, I don't know, Yeoungjee, if you want to have you guys are working on trying to develop some randomized controlled trial in the area of incremental PD, if I understand correctly, and kudos. And we definitely in Canada are very excited about that and would welcome collaboration. But I think it's really exciting times for PDI. And Yeoungjee, I want to thank you for joining us today. Nikhil, as always, for organizing an excellent podcast. I hope what we've impressed upon you is we're looking for high quality, methodologically sound research that's patient-oriented, as Yeoungjee said, focusing on really some of the key clinical challenges we see in PD. And maybe we're moving away from KT over urea and biomarkers and more trying to really better the patient experience of PD. And, I'm really excited that PDI now has very multifaceted research, looking at the patient perspective, looking at rigorous evaluation and standardization of definitions and outcomes, and then taking that, finally culminating it into randomized control trial data. So follow us and continue the conversation at PDI Journal on Twitter. We'd love to hear what you think about today's podcast, and certainly feel free to shoot out questions to us on social media. And as always, thank you for listening to the podcast today, and all the best.
Thanks, Yeoungjee and Jeff, for excellent insights into the editorial process of PDI and discussion of some excellent papers. All papers referenced in today's podcast are linked in the podcast episode details. And thanks, Yeoungjee, again for joining us today. We will have another session similar to this, where we continue discussing some of the other selected papers. That's all for today. This is Jeff and I signing off. And until the next PDExchange, take care.